Hello, everyone. My name is Simran Chaudhary, and I warmly welcome you all to the virtual session on myeloma in India, bridging the gap in care and diagnosis. This insightful session is organized by Voice of Healthcare and proudly supported by Sabia, Fortis Hospital, and Agilis Diagnostics. To kick off the discussion, I'm delighted to introduce our esteemed speakers for the session. First, we have Dr. Siddharth Sharma, Head Clinical and Scientific Affairs, Sabia, India. Sir will share his opening remarks with us. Over to you, Dr. Siddharth.
Thank you. Thank you, Simran, for the warm welcome. And I must also warmly welcome Dr. Nikhil M. Kumar from Fortis Hospital, Gurugram, who has kindly consented to speak on this important topic of multiple myeloma, how testing, he will speak more on the testing strategies, and we'll have very interesting case-based discussions on how testing and therapeutics are playing a very pivotal role in complete patient management. So, Simran, can I have my presentation on screen, please?
Sure. So you can have your
Thank
presentation.
you. So, multiple myeloma, I will just set the context for the proceedings, and then Dr. Nikhil will take over and will have a lot of case-based discussions, which I hope will be very interesting for the audience who has joined. So, multiple myeloma is a malignant disorder of the plasma cells. It is the second most frequent hematological malignancy. It constitutes 15% of all hematological malignancies, and the burden is 1% of the total cancers. There is a slight male predominance. Worldwide, the male to female ratio is 1.1 is to 1, whereas in India, it is considered to be around 1.3 is to 1. If we talk of the per year incidence of cases in myeloma in the US, we have around 21,000 new cases being diagnosed per year. Worldwide, we have around 250,000 cases being picked up worldwide, and around 15,000 deaths occur due to myeloma per year worldwide. In India, the ICMR consensus document for multiple myeloma, which was released in 2017, states that the age standardized incidence of multiple myeloma is around zero point 0.7 per 100,000 population, with around 6,800 cases per year being picked up in India. So, to understand a little bit about the monoclonal immunoglobulin, which is also called as M protein and is considered an important biomarker of multiple myeloma, we just need to understand in short what is immunoglobulin or antibodies and how they are synthesized. So, as this slide illustrates, we all have long bones in a body, and they have something called the bone marrow. The bone marrow is where we have the hematopoietic cells, we have the red blood cells, the white blood cells, and the platelets. And amongst the white blood cells, we have the lymphocytes, and it is the B lymphocyte which has a stimulating property. It gets stimulated by the antigens, and then it activates, proliferates, and differentiates into a plasma cell. And it is the plasma cell which ultimately forms the antibodies or the immunoglobulins. So, multiple myeloma is definitely a malignant disorder of the plasma cells. The patient presents to the physician with varied kind of signs and symptoms, and some of them which are quite common are the bone pains or the fractures. They present with anemia, they present with kidney damage, they have they acquire a lot of infections, they are prone to infections, and also in a laboratory workup, they do end up with hypercalcemia. So these are some of the symptoms which a patient of myeloma will present, and a physician has to be alert to sort of consider multiple myeloma as a differential diagnosis when these symptoms are evident in a patient. So serum protein electrophoresis is a test which a patient who is suspected of multiple myeloma invariably undergoes. So there are two technologies available for doing a serum protein electrophoresis. We have the gel electrophoresis and the capillary electrophoresis. And it's a very simple test in which a serum sample, when undergoes electrophoresis, is separated into six fractions. And this is a classical electrophoretic curve which is obtained, which consists of the major proteins, the albumin fraction, the alpha 1 fraction, alpha 2 fraction, the beta 1 fraction, the beta 2 fraction, and the gamma fraction. And it is the gamma fraction where most of the antibodies are usually present. And if there is a monoclonal protein, it manifests as an abnormality in the gamma fraction. It can be seen in other fractions also. So this is how monoclonal proteins look like. And when we do a serum protein electrophoresis, so you have in the slide above, you have normal plasma cells which are producing varied antibodies, what we call as polyclonal immunoglobulins, and they produce a Gaussian shape or a bar shape, bell shaped curve on the gamma fraction. Vis-a-vis a plasma cell which has undergone malignant transformation, it produces one single isotype of immunoglobulins, which is preponderant in population compared to the other antibody population which exists, and it produces as a sharp spike in the gamma fraction or other fractions wherever the monoclonal protein resides. And so that is what is classically called as an M spike, which indicates presence of a monoclonal protein in the particular patient. So when we talk of multiple myeloma, from its origin to its final malignant transformation, it usually presents as monoclonal gammopathy of undetermined significance, which is also called commonly as MGUS, where the patient is totally asymptomatic but does harbor a monoclonal protein. And then the MGUS transforms into smoldering myeloma and finally into multiple myeloma. So it is the MGUS and the smoldering myeloma stages which are the pre or the asymptomatic precursors of multiple myeloma. So the patients do harbor an M protein, but they are asymptomatic. So all the more it is essential to pick up M protein in such patients and sort of follow them up to see how fast are they progressing to multiple myeloma, so that accordingly preventive measures can be taken. So this is a flow chart which sort of gives in a short, in a lucid way, what are the risk factors in a patient of who can be suspected of having multiple myeloma, and then how the laboratory workup is done in such patients with the classical serum protein measurements and the CBCs. And if there is any abnormality, then serum protein electrophoresis and urine protein electrophoresis form a part and parcel of the diagnostic workup of such patients. So the point here to emphasize is that any patient of multiple myeloma, we need a serum protein electrophoresis as a first line treatment to actually label that patient as harboring an M protein and then work up according to the signs and symptoms of that particular patient. Also, we have the international guidelines from the IMWG, which is the International Myeloma Working Group, which sort of incorporates that serum protein electrophoresis has a very major role to play right in the myeloma patient's journey, right from diagnosis to monitoring. So whether it is the MGUS stage or the myeloma stage or the stages in between, the quantity of the M protein plays a very essential role in not only determining which stage the patient is in, but also once the patient is put on therapeutic regimens to see the decrease or increase or the stability of the M protein and accordingly define in what kind of remission stage the patient is. So it is very essential that serum protein electrophoresis should be carried out in any patient suspected of multiple myeloma. So just to shortly just talk about the importance of screening and early diagnosis for multiple myeloma. So most of the patients diagnosed with multiple myeloma initially present to the primary care physicians. So the physicians themselves should be also adept at recognizing typical signs and symptoms of the disease. So researchers now think that multiple myeloma is difficult to treat because physicians usually delay treatment until the symptoms of myeloma and organ damage are detected. Hence, it becomes imperative to start screening and treating early stage multiple myeloma in the groups of people at the highest risk so that they are provided with the best chance of remission and cure from this disease. So in a nutshell, it is important to, whenever a patient with any signs and symptoms of myeloma comes to a physician, the physician should consider the disease or the disorder as a differential diagnosis and should accordingly order the investigations in which serum protein electrophoresis will definitely help in picking up such cases and also classifying the case if at all there is a presence of an M protein. So with that, I will end this setting session and will hand it over to Simran to introduce Dr. Nikhil Kumar for his presentation. Thank you so much.
Thank you, Dr. Siddharth, for setting up the tone of the session. Now, I would like to invite and welcome Dr. Nikhil, Dr. Nikhil M. Kumar, consultant hematologist at Fortis Memorial Hospital Research Institute, Gurugram, with the DM in clinical hematology from AIIMS, New Delhi. He specializes in myeloma, BMT, and CAR T cell therapy. Welcome to the session, Dr. Nikhil. It's an honor to have you with us. You're on mute.
Thank you, Simran, for that kind introduction. I'll just try and share my screen. Are my slides visible on full screen?
Yes, it is visible,
And
Dr. Nikhil.
am I audible?
Yes.
Yeah, perfect. So, first of all, I lead the clinical program for myeloma and plasma cell disorders at the Fortis Memorial Research Institute, where I work as a consultant in a team of hematology and BMT. We are a team of 10 hemato-oncologists, with 5 on the adult side and 5 on the pediatric side. I thank the organizers for giving us this opportunity to discuss about this very important disease. This is a myeloma awareness month, and as healthcare workers and physicians, this is one disease that we should be really aware of, because as of 2025, there are excellent treatment options available for multiple myeloma, which make their lifestyles and the disease very comparable, and the long-term outcomes are good, as opposed to, let's say, what it was a couple of decades back. Myeloma patients, most of them with a standard risk myeloma, live for more than a decade with the treatment options available to us. But it is very, very important, like Dr. Siddhartha mentioned in his initial presentation, to diagnose these patients early, because once they develop disease related complications like pathological fractures, renal failure, and recurrent infections, then treating them and getting the disease under control becomes an uphill task. So Dr. Siddhartha beautifully summarized the disease, what is a pathology, and what are the initial investigations as per the International Myeloma Working Group. What I would like to discuss with all of you over the next 25 to 30 minutes is a very common problem that we face as physicians. And this is an issue for which we get referrals from physicians, geriatricians, and even general practitioners day in and day out. Serum protein electrophoresis remains to be the cornerstone for screening patients with suspected plasma cell dyscrasias. However, very often, especially in this day and era where serum protein electrophoresis is a part of many of the health checkups for elderly patients, and rightfully so, but very often when a report comes up having a monoclonal protein, we very often do not know what to do with it, and hematology referrals are sought for monoclonal proteins almost on a day-to-day basis. So I'm very sure all of you are aware of the disease. Multiple myeloma is essentially increased production of plasma cells in the bone marrow, and these plasma cell makes abnormal proteins and light chains, which can get deposited in different parts of the body. The most common symptoms that the patients comes to us is unexplained anemia, bone pains which are chronic and which last for a significant duration of time, unexplained increase in the creatinine or renal failure, and many other symptoms like fatigue, recurrent infections, and a small subset of patients are incidentally detected as part of a routine screening and they are asymptomatic. So I would like to take you through 3 to 4 case studies. And these are real patients that we have maybe seen in the last 1 month or so. And these are referrals which have either directly come to us or referred to us either by physicians or geriatricians. So going with the first case, a 72-year-old male patient, diabetic hypertensive, mild anemia on routine evaluation. Since elderly patient with anemia, a serum protein electrophoresis was ordered by the physician who was evaluating this patient, and a M spike of 1.8 gram per deciliter was detected. Patient was referred to us for further evaluation, suspecting a diagnosis of myeloma. Now, the first question is obviously, how do we approach this patient? So from a general standpoint, there are two issues that needs to be looked at. One is obviously to evaluate the cause of anemia, and second thing, to see why is there a monoclonal protein and what further evaluation is required for that. So just like evaluating a standard patient with anemia, we got a complete blood count with a peripheral smear, reticulocyte count, a serum iron profile done for this patient. So as you can see here, the other cell lines were essentially normal with a normal neutrophil to lymphocyte ratio. The MCV was low at 76 femtoliter and the peripheral smear suggested a microcytic hypochromic blood picture. The serum ferritin was low at 6 nanogram per deciliter. Patient was diagnosed with iron deficiency anemia and the hemoglobin improved with oral iron supplementation. Any patient, elderly patient with a iron deficiency anemia or any male patient with unexplained iron deficiency anemia should be evaluated for GI blood loss. In his case, fortunately for us, the entire evaluation, including an endoscopy and colonoscopy, was normal and patient improved with dietary supplementation. Moving to the second part, and this is what I would like to discuss with all of you in today's talk. What do we do for patients in whom a monoclonal protein is detected as part of routine evaluation? The first and foremost thing to understand is having an M band is not equivalent to having multiple myeloma. So we have umpteen instances where patients are terrified and they rush to our OPD saying, I've been diagnosed with myeloma. But the fact is, many a time they would have been screened and a monoclonal protein has been detected as part of a routine test. So it is very, very important to understand that presence of an M band does not equate with a diagnosis of multiple myeloma. So this chart very elegantly describes the various causes of a M spike. And as you can see, the most common cause of having an isolated M band on serum protein electrophoresis still remains to be a monoclonal gammopathy of undetermined significance. This is quite common, so much so that in patients over 60 to 70 years of age, more than 30% of patients can have a monoclonal protein. Many of these patients can be observed without any intervention, but depending on the quantity of the M spike, the type of M band, and other parameters, further evaluation, including a imaging and bone marrow study, may be warranted. There are a whole lot of other causes for a monoclonal protein, and depending on the percentage of plasma cells, as well as the amount of monoclonal proteins and the type, these patients can be categorized into MGUS, smoldering myeloma. When do we say patients have multiple myeloma? Multiple myeloma is essentially a constellation of features where there are at least more than 10% clonal plasma cells in the bone marrow, along with one of the CRAB criteria, which includes hypercalcemia, renal dysfunction, anemia, or bone lesions. Amyloidosis is a very, very close differential where patients can have unexplained symptoms, neuropathy, cardiac failure, skin symptoms, macroglossia, This is one of those conditions where patient is symptomatic for a very, very long time and the diagnosis is missed because patients very often present to either a neurologist or a cardiologist. So this is a very important cause for unexplained neuropathy, cardio failure, fatigue, and other symptoms. And we may have a M band or a light chain in AL amyloidosis. Are monoclonal proteins present only in plasma cell disorders? The answer is again no. There are a whole lot of other conditions where you can have similar abnormal proteins or monoclonal bands in the gamma region. This can include B cell lymphoproliferative disorders like Waldenstrom's macroglobulinemia. Almost all chronic lymphoproliferative disorders can have some amount of M protein. It is also important to understand that many patients with connective tissue disorders, renal disorders, and infections can also have an abnormal increase in plasma cells, which can be polyclonal in many cases, and an M spike. So, in this particular patient, because a M spike of 1.8 gram per deciliter was detected, we went ahead and did a further evaluation. So, the serum free immunofixation showed a IgG kappa monoclonal protein. The kappa by lambda ratio was slightly elevated at 1.35. Now, why is it important to do all these tests and not rely on an electrophoresis alone? It is because the prognosis and the follow-up of these patients depends on the type of M protein as well as the light chain ratio. So whenever we get an abnormal M protein or a monoclonal protein on serum protein electrophoresis, it is very, very important to do an entire evaluation which includes an immunofixation to characterize this M protein and also look at light chain ratio. Because very often we have patients where the SPEP is bang normal, and when we do a light chain ratio, a serum free light chain ratio, you can have abnormally high light chains. So there can be a light chain only, a kappa or lambda restricted multiple myeloma, which may be missed if we do not look at it both as diagnosis and follow-up. The creatinine and serum calcium was normal. Now the two other obvious questions is, does every patient with a M protein warrant a bone marrow examination? Because this is one of those tests that patients are terrified of. It is a painful procedure. So the obvious questions that patients will ask you is, do I really need to get a bone marrow done if I have an M spike? And there are very, very clear guidelines and protocols in place to decide which patient with an M protein requires a bone marrow versus which patient does not. And the second question is obviously to look for bone lesions or any lytic lesions. What is the imaging that I should do? So not all patients with an abnormal M protein requires a bone marrow examination. If patients don't have any end organ damage and the M protein is less than 1.5 gram per deciliter, these patients can be safely observed. So we should consider for a bone marrow in all patients, if the quantity of the M protein is more than 1.5 gram per deciliter, if it is a non-IgG MGUS, so you have an IgA protein or you have a significantly abnormal FLC ratio with abnormalities in imaging, obviously these patients should be considered for a bone marrow examination. But very often we get elderly patients, 70-year-old, 80-year-old with a M protein of 0.2 gram per deciliter with a normal light chain and no other obvious clinical problem associated with an M protein. Needless to say, these patients can be left alone with regular follow-up every 3 to 6 months. It is not necessary to do a bone marrow for every patient with an M protein. And there are many predictive models and there are many risk calculators to see whether the patient requires a bone marrow examination. So this is a screenshot which I've taken from a iStop multiple myeloma website. Many of you might be already aware of this study. For those of you who are not aware, iStop MM is a wonderful collaborative effort where patients from Iceland were screened. The entire population was screened for a monoclonal protein and they were followed up over a period of many decades. So this study provides valuable insights to the natural evolution and the biology of the disease as it evolves from MGUS to smoldering myeloma to multiple myeloma. For physicians and hematologists alike who take care of myeloma physicians, I would highly recommend going back and looking at the iStop MM trials. 3 to 4 trials have been published till date, and they provide really valuable information about the natural history of MGUS. So there are calculators which tell you whether patient really requires a bone marrow examination or not. And all patients with a M spike do not require a bone marrow test. And this is something which is very, very important. And patients can be reassured. We have seen in our practice that the reason for doing a bone marrow very often is the anxiety of the physician more than the patient's warranting a bone marrow. So if the M spike is less than 1.5 gram per deciliter, it is a IgG band which we are seeing, and the light chain ratio is normal, or in a light chain only myeloma of the ratio is less than 8, we can safely avoid a bone marrow and observe these tests. Because this patient had an M spike of 1.8 gram per deciliter, we went ahead and did a bone marrow which showed 7% clonal plasma cells. A PET scan was done which did not show any lytic lesions or soft tissue component. This patient was diagnosed as MGUS and advised for regular follow-up. This patient has been under our follow-up for the last 5 years, doing very well without any other problems or complications. What is important to understand is that the prevalence of MGUS serially increases with age. So for someone who is older than, let's say, 70 years of age, almost more than 5% of the patients can have an MGUS, and someone who's more than 80 to 85 years of age, as high as 10 to 20% of the patients can have an MGUS. And needless to say, all these patients do not warrant any myeloma treatment. So this is something which Dr. Siddhartha had also shared in his presentation. When do we label patients as MGUS, smoldering myeloma, and multiple myeloma? These are widely available, and Dr. Rajkumar publishes review articles on multiple myeloma every 2 years in the AJH, the last one being published in 2024, where he comprehensively covers both the diagnosis and the upcoming treatment options for this disease. But couple of things I would like to highlight is for labeling a patient as multiple myeloma, it is important that the plasma cells are more than 10%, or there is a biopsy proven plasmacytoma, and these plasma cell has to be clonal. In one of those cases, I will try and demonstrate how clonality is important in determining the diagnosis. End organ damage is a must, with patients having hypercalcemia, renal insufficiency, anemia, and bone lesions detected by the appropriate modalities. A few other criteria have been added on along the years, where if patients have a clonal plasma cells of more than 60%, or involved to uninvolved light chain ratio of more than 100, or if there are more than one focal lesions detected on the MRI, these also classify as myeloma defining events. If the clonal plasma cells are less than 10% and there are no end organ damage with the monoclonal protein less than 3 gram per deciliter, patients are diagnosed to have a monoclonal gammopathy of undetermined significance, and these patients can be safely followed up every 3 to 6 months with a serum protein electrophoresis and a serum-free light chain assay. Once a patient is diagnosed with MGUS, this is something which causes a lot of anxiety for the patient as well as the family. It is important to understand and reassure the patient that the rate of progression from MGUS to multiple myeloma is only 1 to 2% per year. So as long as patient is not having red flag signs like fatigue, constitutional symptoms, bone pains, organomegaly, or features of amyloidosis like swelling in the legs, unexplained heart failure, macroglossia, these patients can be safely followed up in the OPD, and it is not necessary to put them on any treatment. Are MGUS patients at high risk of developing other medical issues? Answer is partly yes. These patients, because of our immune dysregulation, are at a slightly high risk of developing infections. And there is some data to show that cardiovascular abnormalities and other problems are relatively common in patients with MGUS. But this may also be due to a referral bias due to the fact that these patients present more often to the hospital for unrelated symptoms and they are usually diagnosed with MGUS. So, while these patients do not require any myeloma directed treatment, it is important to understand that these patients are at high risk of infections, second malignancies, venous thromboembolism, and osteoporosis related complications. So, it is very, very important to vaccinate these patients according to the age, a bare minimum of a yearly influenza vaccine, a full course of pneumococcal vaccination, and vaccination for Shingrix is recommended for all patients with MGUS. These patients should be screened for osteoporosis, and osteoporosis directed treatments like zoledronic acid should be administered at the earliest, along with calcium and vitamin D to prevent bone related problems. Between MGUS and myeloma, there is a gray area where patients can have a monoclonal protein which is not really fitting into the definition for multiple myeloma, but they can have problems because of the clone either in the kidney or in the nerves or other areas. So there is a concept called MGCS, or monoclonal gammopathy of clinical significance, which basically means even if I have a very small monoclonal protein and that is causing renal damage, or if I do a kidney biopsy for unexplained renal failure and I see that there is a light chain restriction in the kidney, these patients still warrant treatment regardless of the size of the clone. So this is termed as MGRS, or monoclonal gammopathy of renal significance. So it is also important to realize that other than progression to multiple myeloma, patients with MGUS can face a majority of other problems like increased risk of infections, osteoporotic fractures, and sometimes clinically relevant issues like renal dysfunction and neuropathy, which can mandate treatment of the monoclonal protein, even if it is not fitting into the criteria for multiple myeloma. So the key takeaway from this case, M-band is not synonymous with myeloma. It is a harbinger of issues. M-spike should be evaluated further with bone marrow and imaging, which is required in a select group of patients. Roughly, there is a 1% per year risk of progression of MGUS to multiple myeloma. A few other complications are common in these patients. Hence, vaccination and screening and treating osteoporosis is of utmost importance, especially considering the fact that many of these patients are elderly and at increased risk of infections and fractures. Moving on to the second case, a 48-year-old uncontrolled diabetic with a new onset renal dysfunction and anemia. A serum protein electrophoresis was done, which did not show an M spike. Immunofixation showed a faint band in the IgG kappa region. A serum free light chain assay was done as part of the myeloma evaluation, and the kappa by lambda ratio was elevated at 2.6 with a kappa light chain of 102. And patient was obviously referred to hematology in view of the high FLC ratio. Now, this is a scenario which we face very often where patients have a renal dysfunction. Patients may come to us with a CKD, and there are multiple other risk factors like diabetes, hypertension, which may be responsible for the CKD. So the obvious question that comes to our mind when we see this patient is how much of a contributory factor is the monoclonal proteins when it comes to renal dysfunction? Considering that the M spike is normal and there is a very, very faint band in the IgG kappa region. Ultrasound was done as part of the evaluation and there was bilaterally small contracted kidney. A bone marrow examination in this case did not reveal any clonal plasma cells. PET-CT was normal with no lytic lesions detected. There were no monoclonal proteins detected in the 24-hour urinary protein electrophoresis also. So patient was diagnosed with diabetic CKD and the anemia was attributable to CKD in this case. Now we might wonder, why did the patient have an abnormal light chain ratio? So this is something which most of us don't realize in our routine practice, that the light chain ratio is altered in CKD And depending upon the creatinine clearance, a light chain ratio of as high as 3.3 can also be normal for an end-stage renal disease. This is because of the fact that while the production of light chains is not increased in these patients, because of a chronic kidney disease, the excretion is impaired. And since the production of kappa light chains is more than lambda on a day-to-day basis, the light chain ratio can get skewed. So while 0.26 to 1.65 is a normal light chain ratio in patients with a normal creatinine clearance, it is equally important to realize that as the degree of renal dysfunction increases and as the EGFR drops, a higher light chain ratio of up to 2 to 3 can also be normal in these patients. So when a CKD patient comes to us, or when patients with a renal dysfunction come to us with a light chain ratio of, let's say, 2.6 to 3, these may be because of the CKD, and these may not indicate the fact that patients have a monoclonal protein. So the last patient that we discussed here, we did an entire evaluation including a bone marrow, PET, and everything, which was normal. So essentially the cause of an abnormal light chain ratio in his case was the CKD, and this was not a monoclonal protein. So light chain ratio is altered in CKD as the excretion of light chain is impaired. And as we discussed, a FLC ratio of almost up to 3 can be normal in these group of patients. MGRS is a very, very difficult diagnosis to make, and any patient with an unexplained renal dysfunction should be suggested for a renal biopsy to look for a light chain restriction. And it is important to understand that MGRS or any clinical symptom because of a monoclonal protein may not be proportional to the clone size. So very often you can have patients with an M spike of 0.2 or 0.3, but when we do a renal biopsy, there is light chain deposition and renal dysfunction because of that. So this comes into the category of an MGRS or a monoclonal gammopathy of renal significance, and this should be treated like a multiple myeloma itself. Coming to the third case, so this was one patient in whom a diagnosis was delayed by almost 2 to 3 months, despite consultations from multiple departments, including hematology. So a 46-year-old lady initially presented to the neurologist with new onset weakness, pain and burning sensation in the limbs, sensory motor neuropathy, initially diagnosed as AIDP, treated with IVIG, subsequently steroids. There was no improvement in symptoms. The patient consulted a hematologist also, where they did a serum protein electrophoresis, serum free light chain assay, both of which came out to be normal. Since the neuropathy was progressing and not responding to treatment, they got a PET-CT to done, mainly to look for a paraneoplastic syndrome. And surprisingly, there was a sclerotic lesion in the D5 vertebra detected on the PET scan. So as you can see here, patient was evaluated for a monoclonal protein with a electrophoresis light chain. The only clue that was there was a very, very small band which was detected by serum immunofixation in the IgG lambda region. But due to the fact that a PET-CT was already done and there was a sclerotic lesion in the PET-CT, there was a very, very high suspicion for POEM syndrome in this patient, because of which a bone marrow examination was done, which showed 8% clonal plasma cells. Patient underwent further evaluation for POEM syndrome. VEGF levels were done, which was elevated. And based on the standard diagnostic criteria, patient was diagnosed with POEM syndrome. Patient was started with a standard myeloma treatment, initially Lendex, followed by an autologous transplant. And there was significant improvement in the symptoms, and the disease remains in remission for 5 years post-transplant till the last follow-up. So this is one of those cases which emphasizes the importance of looking for a clone, even if it is present in a very, very small amount. In POEM syndrome, MGRS, or any other monoclonal gammopathy of clinical significance, the clinical symptoms may not correlate with the size of the clone. Like in this patient, initially the monoclonal protein was missed because a serum immunofixation was not done, and the serum protein electrophoresis and the light chain ratio was essentially normal. But retrospectively, because a PET scan was done which showed a sclerotic lesion, we went ahead and got an immunofixation and bone marrow, which showed a clonal protein, and VEGF levels and other endocrine evaluation was done. So the take-home message essentially from this for us as hematologists and as physicians is the fact that whenever there is a high suspicion or whenever there is a patient with unexplained neuropathy, we should get an entire complete evaluation done to rule out a MGUS, and a screening with SPEP may not suffice as a test to really rule out an MGUS. Immunofixation, light chain, and sometimes even bone marrow examination may be essential in these patients. So the key takeaway for us from this case was to look for a monoclonal protein in patients with unexplained neuropathy. Very, very small clones may be missed by serum protein electrophoresis or even light chain. So immunofixation is paramount in these patients because even such a small clone can cause significant neuropathic symptoms in MGCS. A clone-directed therapy leads to significant improvement in the clinical condition of patients. So this is a whole lot of diseases which come under the umbrella of monoclonal gammopathy of clinical significance. As you can see, this can involve almost every organ of the body, and depending on the symptoms, patients can present to different specialists. And because these are extremely rare diseases, these diagnoses is very often missed. The list goes all the way from amyloidosis, Poem syndrome, to relatively rare diseases like Tempe syndrome, Clarkson's disease, and so on. But the overall understanding of the fact that a monoclonal protein can cause unexplained symptoms in multiple organs should be there among physicians and healthcare providers. So any patient presenting with unexplained symptoms, either relating to the heart, peripheral neuropathy, renal, or even unexplained skin symptoms, lymphadenopathies, and other symptoms, should be evaluated for a monoclonal protein by a complete myeloma profile, including a serum protein electrophoresis, immunofixation, and a light chain assay. Moving on to the next case, a 54-year-old male patient, no prior comorbidities. This patient was detected to have a by G reversal. The total protein was high and the albumin by globulin ratio was reversed on routine evaluation. Patient had absolutely no symptoms. The tests were done as part of a routine annual checkup and the total protein was detected to be high. Obviously, a serum protein electrophoresis was done, which showed an M spike of 2.1 gram per deciliter, with the light chain ratios just slightly raised at 1.8. Patient did not have any other abnormal symptoms, no end organ damage. Obviously, because the SPEP showed a high M spike, a bone marrow examination and a PET scan was done. So the bone marrow examination showed 18% clonal plasma cells, which is clearly more than 10%, which is required for the diagnosis of a smoldering myeloma or a multiple myeloma. A PET-CT, which was done at an outside center, showed no lytic lesions. So this patient, before he came to us, was diagnosed with smoldering myeloma and was advised routine follow-up. And patient came to us for a second opinion because obviously looking at all these reports, the family was very, very anxious and they really wanted to know whether this requires a treatment or observation. It is standard practice at Fortis Memorial Research Institute, where we have seen quite a few patients with no obvious lesions on a PET-CT. But when we go ahead and do a whole body MRI, very, very tiny lesions may be picked up. So before labeling the patient as smoldering myeloma, we always do an MRI to look for any small lesions. So this is standard practice. And we did a whole body MRI for this patient, which showed 2 to 3 focal lesions in the spine. Very, very small, 1 centimeter lesions. But if you go back and look at the diagnostic criteria, any focal lesion of more than 5 millimeter on an MRI, more than one lesion is also a myeloma defining event. So in this particular case, though he was completely asymptomatic and there was no other issue, considering that there were 18% clonal plasma cells along with focal lesions on the MRI, this patient was diagnosed as multiple myeloma and started on treatment immediately. Had we observed this patient saying the patient has smoldering myeloma, within 3 to 4 months, patient would have come to us with some myeloma defining event. So Smoldering myeloma is a very, very difficult diagnosis to make, and we should be extremely careful and we should double check everything before really saying that the patient has a smoldering myeloma. This is because very often we have seen patients being referred to as a smoldering myeloma just because they don't have any anemia, renal dysfunction, hypercalcemia. Many of them do not even get a PET done. In 2025, I would like to emphasize on the fact that a whole body CT or chest X-ray or a screening X-ray is no longer sufficient to diagnose myeloma defining bone lesions. If we do a CT and bone lesions are seen, then that is fine. But a normal CT or sometimes even a normal PET CT may not be sufficient to say that this patient does not have any myeloma related bone lesion. And in conditions where your entire treatment depends on the fact that there is a bone lesion versus no lesion, we should go all the way, get an MRI done to look for any focal lesions, ideally both an MRI and PET CT. But if there is a major cost constraint, at least a whole body MRI should be done before really labeling the patient as smoldering myeloma, so that we do not miss patients with multiple myeloma, misdiagnose them, and follow them instead of starting treatment. So this is a very, very important differentiating feature to make. The choice of imaging modality matters. While PET-CT suffices for most patients, it is important to understand that a small cohort of patients can have an absolutely normal PET with very small focal lesions picked up on the MRI, and this can make the difference between SMM and MM. Whether we should treat high-risk smoldering myeloma is a discussion for an altogether different topic. But if patients have high-risk features, including a high M spike or bone marrow plasma cells, which are more than 20-30%, a discussion should be held with the patient whether to go ahead and treat these patients or wait. We will not go over the intricacies of myeloma treatment, but it is important to emphasize on the fact that both standard risk, high risk, transplant eligible, ineligible patient, daratumumab or an anti-CD38 monoclonal antibody is an essential part of treatment. A quadruplet treatment is recommended for all patients with standard risk as well as high risk multiple myeloma. The standard practice that we follow is to treat patients with DARA VRD for 3 to 4 cycles. All patients with a newly diagnosed myeloma should be encouraged to undergo a autologous stem cell transplant, because this is one of those modalities that significantly improves the disease control and progression-free survival of more than 2 to 3 years, especially for standard risk patients. Post-transplant, we continue the patients on a maintenance strategy to make sure that the disease remains under control for the longest possible time. Now, whether we need to give a single drug maintenance or a double drug or two drug maintenance depends on the risk stratification as per IMWJ, where patients with high risk features like deletion 17p, 1q gain, translocation 414, and many others should be encouraged for a double maintenance with bortezomib and lenalidomide. Even for patients who are transplant ineligible, daratumumab is a wonderful drug to control the disease and continue as a maintenance, where patients should be given optimal treatment before switching to a maintenance strategy. Before I end my talk, I would like to share this with all the healthcare workers and the physicians who are listening to us today, that we have two clinical trials of bispecific antibodies in the treatment of multiple myeloma. We have the Majestic 9 trial, where patients are given teclistamab versus the standard treatment modalities, and a Monumental 6 study, which is a phase 3 trial of bispecific antibodies like teclistamab and talquetamab, comparing with the standard treatments like pomalidomide and elotuzumab. So when patients relapse after the first line treatment, it is very, very important for us to understand that in 2025, we have immunotherapy, which is highly effective in the myeloma treatment. So we have these drugs, both teclistamab and talquetamab, as part of standard clinical trials at Fortis, and a myeloma CAR-T trial is also ongoing at Fortis. I'll stop here. We are able to do whatever we are able to do for our myeloma and plasma cell disorders patients because of this wonderful team. This is one of the first globally recognized hematology teams in the country where we have successfully performed more than 1,000 transplants. So, treating hematology patients is a team effort where a lot of people, including an infection disease specialist, a critical care hematologist, a hematopathologist, nutritionist, physiotherapist, a large team of nursing coordinators and doctors need to monitor the patient round the clock. We are the first center in the country which has started genetic studies for multiple myeloma in the form of next generation sequencing, which we offer for our myeloma patients. All these state of the art tests and treatment modalities like immunotherapy are available at Fortis at affordable prices. And with this entire umbrella of treatment that we have for myeloma, we are able to provide the best possible care for these patients. This is our team of doctors at Fortis Institute of Blood Disorders. I'll stop here and I'm happy to take any questions.
Yes. So thank you, Dr. Nikhil. It was a really interesting presentation. You have taken us through real-time case presentations covering the whole gamut, the spectrum of how monoclonal gammopathies can present, and also to make understand that always an M protein is not a monoclonal gammopathy. There are other causes also. So it's basically to arrive at a pinpoint diagnosis without unnecessarily alarming the patient. So I guess that's the take home message. So there are some questions, and we have some time with us. So I will take few of them. So
Yes,
there
yes,
is
please. I think I'll
one.
just stop sharing my screen so that
Sure,
you
sure.
can just have a look at the questions.
So the questions are in the chat box. So there is
Yeah.
one question. I guess this is a very important question. So, what are the most common reasons for delayed diagnosis, and how can they be avoided?
That's an excellent question. Like we mentioned at the start of the session, the biggest problem in multiple myeloma and plasma cell disorders is a significant delay in diagnosis. When it comes to other plasma cell disorders like amyloidosis, this delay can sometimes be catastrophic. Now, I'll tell you what are the common reasons why the diagnosis is delayed. The first and foremost reason is that unlike many other diseases like, let's say, leukemia, lymphoma, and the conventional blood cancers, patients with myeloma usually do not present to a hematologist with symptoms. Their symptoms can involve almost any organ in the body. So let us say a patient has a neuropathy, they go to a neurologist, and obviously a neurologist would evaluate first for common causes of neuropathy. The same way, if there is a problem in the kidneys, the creatinine is raised, they would go to a nephrologist, and the nephrologist would evaluate them for CKD, and then eventually, if other causes are not found, then the myeloma evaluation is done. The situation is even more serious when it comes to diseases like amyloidosis, because we have seen umpteen number of patients having unexplained renal dysfunction, unexplained proteinuria, problems in the heart, cardiac failure. So the reason for a delay in diagnosis is actually a lack of awareness about the fact that plasma cell disorders can affect almost any organ in the body, and the symptoms can be really varied. So it is very, very important to understand as physicians and as well as general public that any patient with an unexplained renal dysfunction, unexplained anemia, especially in the elderly patients, have slightly low hemoglobin. We treat with B12, folic acid, iron 1 month, 2 months, no improvement. These patients have to be treated or have to be evaluated. So, like Dr. Siddhartha rightly mentioned, serum protein electrophoresis and serum free light chain assay, these are two very simple blood tests which can effectively pick up more than 90% of the patients with plasma cell disorders like myeloma and amyloidosis. And this should be part of the standard protocol when it comes to evaluating patients with renal dysfunction, neuropathy, anemia, bone pains, and whole lot of other symptoms. The important fact is that once patients develop these complications, then the myeloma will get better, the plasma cell disorder will get controlled. But let's say patients go on dialysis, almost 40 to 50% of them remain on lifelong dialysis. So the fact that patients present to different clinicians or different specialities and lack of awareness about the symptoms of myeloma and amyloidosis are the most common reasons for delayed diagnosis. And I think programs like this, more awareness about the diseases, and sessions involving physicians, hematologists, as well as general practitioners would go a long way in ensuring that every single myeloma patient is diagnosed appropriately and given the best possible treatment.
No, perfectly said, perfectly put. I mean, this is what is required. Awareness is something which is lacking in physicians, and the patients usually present to the physicians or to the concerned specialists for their symptoms. And unless the suspicion exists, further workup will not be done. So that's very rightly put, Dr. Nikhil. So, time for one more question. And the question is, if a patient is diagnosed with monoclonal protein but has no symptoms, how often should they be monitored?
So that's again a good question. So if there is a monoclonal protein and no symptoms, patients can fall into two categories. Either patient can have a monoclonal gammopathy of undetermined significance or an MGUS, or patients can have a smoldering myeloma. Now, even in MGUS, there are low risk and high risk MGUS based on features like how much is the monoclonal protein, what is the type of protein, and other things. But a rough estimate is that patients with MGUS, there is approximately a 1% chance of disease progression, while patients with smoldering myeloma, there is a significantly higher risk of 10% chance per year for the first 3 years, followed by almost 5% for the next 5 years, and then 3% thereafter. So all these patients should be followed up initially with a 3 monthly serum protein electrophoresis and serum free light chain assay, and along with obviously a close watch for symptoms like back pain, fatigue due to anemia, and other workup. So it is our standard practice if a patient is diagnosed with MGUS, initially for the first 1 to 2 years, we follow them every 3 months with a complete myeloma profile, CBC, LFT, RFT, which includes a calcium, creatinine, hemoglobin, and also a symptomatic assessment. If the patient's disease is remaining steady, then after the first year, we follow them every 6 months with these tests. As far as smoldering myeloma is concerned, the frequency of follow-up would actually depend on the type. If there is a high-risk smoldering myeloma, and there are very standard criteria for this, these patients should be followed up every 2 months, and any slightest symptom of a worsening anemia or an increase in creat or any myeloma defining event, a bone marrow examination should be done. Smoldering myeloma patients once in every 2 to 3 months, MGUS patients once in 3 to 6 months. And if there is any suspicion, an entire evaluation, including a bone marrow study and a PET scan, should be done.
Right. So I guess that answers the question. So I'm afraid we are now out of time. So I will request Simran to take over and bring the session to an end. Over to you, Simran.
Thank you so much, Dr. Siddharth, and thank you so much, Dr. Nikhil. So, it was a very wonderful and insightful session. So, I would like to thank our esteemed speakers, Dr. Nikhil M. Kumar and Dr. Siddhartha Sharma, for sharing their valuable insights and expertise with us today. We also extend our gratitude to our engaged audience for their participation, and we hope the session has been informative and meaningful. So, thank you so much, all the speakers and the listeners out there, as our aim is to create this education awareness about such important and sensitive topic. So, thank you so much for this session, and stay connected and have a great day ahead.
Thank
Thank you.
you. Thank you, Simran. Thank you, Dr. Nikhil.
Thank you all. Thank you, Dr. Siddhartha and Simran, for organizing this wonderful session. And I really thank all of you who have taken your time out this evening to join us for this educative session. Thank you all.
Thank you so much, sir. It's a pleasure.